I'm Dr. Robert Jones, and in this lecture we're going to discuss how to use focused echo to determine the presence of right heart strain. Direct visualization of the pulmonary embolism with transthoracic echo occurs rarely. Transthoracic echo is able to show the indirect findings of a pulmonary embolism, such as RV dilatation, inferior vena cava dilatation, McConnell's sign, and septal flattening or bowing. Looking at RV dilatation, it should be noted that the right ventricle should be no larger than 0.6 to 1.0 times the size of the left ventricle. It's important to remember that absence of RV dilatation does not exclude the diagnosis of a pulmonary embolism, and the corollary of that is that the presence of RV dilatation does not confirm the diagnosis of pulmonary embolism. There's multiple other reasons that RV dilatation could be present, such as cor pulmonale or chronic cardiomyopathy. But here was a patient who had an acute PE, and you can see that there, just visually, even without measuring, that the right ventricle is massive compared to the size of the left ventricle. So looking at right ventricular dilatation a little bit further, here again is the case of the patient with a documented pulmonary embolism. You see the dilated RV, you can see paradoxical septal wall motion here, you can see flattening of the left ventricle. Yet here is a patient who was asymptomatic but had a known history of cor pulmonale. Again, in this patient you can see a dilated right ventricle, and you can see bowing of the septum with paradoxical wall motion and compression of the left ventricle. So you have to use clinical correlation in these cases. The presence of RV dilatation is a non-specific finding. The presence of McConnell's sign can be useful in evaluating the patient for a suspected acute DVT with acute right heart strain. And McConnell's sign is where you have normal wall motion down by the apex, but the remaining free wall of the right ventricle is stunned or akinetic. Now, this is poorly sensitive. You can't use this to rule out the presence of a PE, but it's highly specific for the diagnosis of a PE. And this was a critically ill patient who came in hypotensive and was found to have a large saddle embolus. If you look here, just with the visual estimation, the right ventricle is larger than the left ventricle, and you can see that the apex here of the right ventricle has preserved function, but the remaining parts of the free wall is akinetic. And this is something that you don't see in chronic cor pulmonale or chronic right heart strain. This is a finding that's, as mentioned, poorly sensitive, but it is highly specific for the diagnosis of acute right heart strain. Now here are apical four-chamber views from two different patients. This one was off-axis, but this patient was critically ill and could not be positioned and was extremely tachypnic. But here's a normal patient. If you take a look, here's the right ventricle, here's the apex, here's the remaining part of the free wall. You can see that there's a concentric squeeze in, and there is a relatively even function from the apex to the remaining part of the free wall. You can see that even to naked eye estimation that the RV here is not larger than the LV. However, in this patient here, and granted it's a little bit off axis, but you can see that the right ventricle is dilated compared to the size of the left ventricle, and you can see that the vast majority of the free wall here is akinetic, but there's preserved function down by the apex. This was another patient with a large central pulmonary embolism who had McConnell's sign. Now here are two more patients, and we have apical views from both. This patient on the left has biventricular heart disease. You can see that there's thickening of the walls of both the RV and of the LV. You can also see that this patient has a pacemaker and AICD in place. You can see the echogenic catheter. If you notice, this patient has symmetric contraction of the entire free wall and apex of the RV. Contrast this to, again, a patient with a central pulmonary embolism and acute right heart strain. An akinetic free wall and a normal or even hyperdynamic apex of the RV. This is a McConnell sign. Here's another patient with a large pulmonary embolism. Again, this is less than an ideal image due to the fact that this patient was critically ill. But you can see here on this pseudoapical window that the vast majority of the free wall here is hypokinetic, but there's preserved function of the apex here. Again, another patient with central PE and with McConnell sign from the acute right heart strain. Now here's another patient. Again, this was a patient with a very large central PE. He was hypotensive and hemodynamically unstable. If you take a look just to the naked eye, the right ventricle is larger than the left ventricle. You can see that the vast majority of the free wall here of the right ventricle was hypokinetic, but that there's preserved function of the apical portion. This was another patient with McConnell sign. Let me show you one more patient with McConnell sign. Here you can see again, it's a pseudo-apical view. This was again another patient who was grossly hemodynamically unstable and could not be positioned. But you can see there's preserved or even hyperdynamic function of the apical portion of the RV with severe hypokinesis of the remaining parts of the free wall. This was a patient who had a large saddle embolus. So this is something that right from the beginning I want you to keep your eyes out for when you're scanning. Make sure on every apical four-chamber view that you look to see the size of the RV compared to the LV, and take a look at the contractility of the apical portion of the right ventricle as well as the remaining parts of the free wall. Next, let's look at bowing of the septum. Bowing or flattening of the interventricular septum occurs with high right-sided pressures. They call this a delta sign because the left ventricle appears to be in a D-shaped. Now, this is something that can occur with either acute or chronic RV strain. So the presence or absence of bowing cannot be used to exclude or make the diagnosis of PE. It's just one more piece of the puzzle when you're clinically evaluating these patients. External short axis windows in two different patients. This patient here has a normal cardiac exam, and if you look, the RV is not dilated as compared to the LV, and if you look at the left ventricle, there's symmetric squeeze in during systole and relaxation during diastole. There is no bowing or paradoxical movement of the septum. Now take a look at this patient who has a large central pulmonary embolism. You can see just with the naked eye that the right ventricle in this parasternal long axis window that the RV is dilated as compared to the LV, and you can also see that there's paradoxical bowing of this septum due to high right-sided pressures. Here's another patient with a large saddle pulmonary embolism. This was a young patient with no underlying history of cardiopulmonary disease, but you can see that the RV is extremely dilated. You can see that there is paradoxical movement and bowing of the interventricular septum, and it's creating that delta sign. This was a patient with a large pulmonary embolism. Let's look at dilatation of the inferior vena cava. This is a nonspecific finding, and it just shows that there's elevation of the right atrial pressures, and this could be due to anything from chronic cor pulmonale to congestive heart failure to pulmonary embolism to tension pneumothorax. So it's important to remember that this dilatation of the inferior vena cava can be due to multiple other causes. Here you've got the sagittal view of the inferior vena cava. Here's where the hepatic vein is coming in. You can see that the inferior vena cava is dilated. It measured 2.7 centimeters. And you can see that with sniffing, there's essentially no respiratory variation. So this would go along with high right-sided pressures. But again, it's a nonspecific finding. It's important to remember that absence of dilatation does not exclude the diagnosis of pulmonary embolism either. So before concluding, let's take a look at the bottom line. Remember, direct findings of pulmonary embolism rarely are seen with transthoracic echo. McConnell sign is poorly sensitive, but it's highly specific for the diagnosis of acute right heart strain. The indirect findings seen on transthoracic echo need to be correlated with the clinical case. What I mean here is a patient who comes in is hypotensive but has a history of underlying cardiomyopathy and cor pulmonale, who's found to have a dilated RV and a evidence of bowing of the intraventricular septum. This patient has multiple reasons for having RV dilatation as well as bowing of the intraventricular septum. Could the presence of a McConnell sign be helpful? Maybe, but this is clearly different than the 24-year-old female who comes in after a syncopal episode, is hypotensive, has no underlying cardiopulmonary disease, and is found to have bowing of the intraventricular septum, a very dilated right ventricle. This would be highly suggestive of acute right heart strain based on the history. If there was McConnell's sign present, then this would be even more suggestive of the presence of acute right heart strain. And lastly, remember, pulmonary embolism cannot, and I emphasize that, cannot be ruled out based on the absence of right heart strain on transthoracic echo. This now concludes the acute right heart strain lecture. I'm Dr. Robert Jones, and in this lecture we're going to review how to use focused echo in the crashing patient. How many times have you been involved in a patient who's crashing, or the cardiac arrest patient, and there's significant question as to whether or not the patient has a pulse or not? Remember, palpation of peripheral pulses or even central pulses can be difficult to assess in the profoundly hypotensive or cardiac arrest patient. And what you really need to know is, does the patient have organized cardiac activity present? And this is something that focused echo can be very helpful in determining. Now, pulseless electrical activity is going to be defined as the absence of peripheral pulses in the presence of organized cardiac activity. Now, you want to rapidly evaluate these patients and look for the potential cause of their PEA arrest. This is going to be what will give the patient the best chance at having a meaningful recovery and outcome. And focused echo as well as focused ultrasound can be very helpful in diagnosing PEA and then looking for potential causes. Here was a patient who came in, no peripheral pulses could be felt. You could see that on the monitor there were organized complexes, but the question is, did the patient have true organized cardiac activity? And on focused echo, you could see that yes, this patient does have organized cardiac activity. You could also look to see, does the patient have a large pericardial effusion with tamponade physiology? You could look to see if the right ventricle was dilated and potentially the patient has a saddle pulmonary embolism. You could look to see if the LV function was hyperdynamic and that the ventricular walls were opposing or kissing at end systole, making you think of hypovolemia. This could allow you to extend the focused ultrasound exam to look into the abdomen for hemoperitoneum, as well as to look for signs of ruptured AAA. So there's a lot that ultrasound can be used for, and it can be rapidly used to help these patients. Here was another patient that came in a PEA arrest. The question was, once again, did this patient have organized cardiac activity? And you could see on this apical view here that yes, the patient does have organized cardiac activity. And again, you can now start looking for potential causes of this. Here was a subcostal view of the same patient. And yes, again, you notice that there is organized cardiac activity. Here's another patient that came in. Pulses couldn't be palpated. Focused echo was quickly done. And yes, there's organized cardiac activity. And this patient has a large pericardial effusion with tamponade physiology. So not only was the focused echo exam able to tell us that there was organized cardiac activity, it was able to give us a reason for the PEA arrest and allow us to then rapidly treat this. Here was a young woman who was picked up by EMS after a syncopal episode. En route, they said that they lost her pulses, and when she came in, no peripheral pulses could be palpated, but on the monitor, it was noted that she had a narrow complex rhythm with a rate in the 120s. Went ahead and quickly did a focused echo exam, which showed that there is indeed organized cardiac activity, and what we see in addition to that is that the right ventricle is significantly dilated. You can see that the LV function is hyperdynamic, and on the parasternal short axis you can see again that the RV is dilated. You can see that the LV is being compressed and that you've got the delta sign here, so there's paradoxical septal motion here. This was a patient who had a large pulmonary embolism as their cause of a PEA arrest. So rapid bedside echo helped us to know that there was organized cardiac activity and then helped us to diagnose the cause of this and to rapidly treat the patient. Here's a patient who came in PEA arrest after having been shot multiple times. According to EMS, he just lost his pulses as he was being transferred into the emergency department. If you take a look here at his heart, you can see that there is organized cardiac activity, but you really don't even see much of a chamber on either the left or the right side, and that's because this patient was profoundly hypovolemic due to the blood loss from multiple gunshot wounds. So this exam was first done to see if there was evidence of hemopericardium since he was shot in the chest. There is no evidence of that, but quickly looking at the heart, you could see that it's hyperdynamic. The chambers were essentially empty, and there was opposition of the walls at end systole, all consistent with severe hypovolemia. In an older patient, you could consider things if there was no hemoperitoneum, such as a ruptured AAA. If this was a young female who was pregnant, this could be due to a ruptured ectopic. So again, ultrasound is very beneficial here. Here was a 40-ish-year-old male who had collapsed and was in cardiac arrest when EMS got there. Intermittently, they said he had return of spontaneous circulation. However, when he was brought into the emergency department, we couldn't feel peripheral pulses, and there was a wide complex rhythm noted on the monitor. As ACLS was continued, a quick focused echo was performed, and what we saw was that yes, there was indeed organized cardiac activity, but what we noticed, and again, this is not a part of the focused echo exam, but it was something that we were able to recognize in this case. The patient has good movement of the LV posteriorly, but the entire anterior wall was not moving. It was not thinned, making us think that this was from an old infarct. So our suspicion was that this patient had a large anterior wall MI. So once we were able to stabilize the patient, we obtained an EKG that showed that the patient was having a large anterolateral MI, and even though detection of focal wall abnormalities was not a primary goal of our study, in this case it was so obvious that it helped us to understand the cause for this patient's PEA arrest and to appropriately treat him in a very expedited fashion. I just want to take a second here to bring up the point that you really have to limit the time you take in performing the echo. If you look at all the new changes that have occurred in ACLS, it's now all about high quality CPR without breaks or very minimal breaks. You want to perform these focused echo exams when the breaks are being performed over the 5 or so seconds that these breaks are being performed. What you don't want to do is have CPR stopped and then take 30 to 60 seconds performing an echo. This is not what you want to do. Just perform these exams very quickly. If you want to record a video at the time you're doing it so that you can then review that once CPR is started, that would also be fine, but really limit the time that you're spending in performing these echoes. Here's a patient that comes in. EMS has been doing ACLS protocol on the patient. The patient had no return of spontaneous circulation out in the field. When the patient is brought in, you look at the monitor and you see that there's wide complex rhythms and a rate in the low 40s. You perform a focused echo, and this is what you see. Here's a parasternal long axis, so you get the right ventricle, left atrium, left ventricle, aortic outflow tract, and here's a subcostal window right here. Does this patient have any organized cardiac activity? And the answer is no. This patient was in asystole, so based on these echo findings, we pronounced the patient at that time. Here's another patient who came in, and on the monitor there were QRS complexes. We did a quick focused echo, and this is what we saw on the parasternal long axis. So this is RV, LV, LA, aortic outflow tract. There's the mitral valve. There's a descending aorta. So if you look, there's no obvious large pericardial effusion. What you notice here also is that there's no organized cardiac activity. You see little flickers of the valves, but this does not count as organized cardiac activity. There's no organized squeeze of the LV. This patient sonographically was in asystole. The chance that you can resuscitate these people is very slim to none. So based on the fact that this patient had been in pre-hospital arrest, had no evidence of cardiac activity on arrival, this patient was also pronounced. Here's a trauma case. This was a 24-year-old male with a gunshot wound to the left chest. Per EMS, patient was awake and alert on arrival. He deteriorated rapidly en route, and on arrival, they noticed that he was in full cardiac arrest, and they initiated CPR, bringing him into the trauma bay. So you go ahead and perform a rapid focused echo exam, and this is what you see. You take a look at the heart. You can see, first of all, here's the right side of the heart, here's the left side of the heart. There's a very large echogenic effusion surrounding the heart. You can also see that there is no true organized cardiac activity. What we also noticed is that this patient had his gunshot wound to the left lateral chest with no exit wound. It appeared that the bullet had crossed here from the left ventricle across the septum and across the right ventricle. But this was a patient who arrived to the trauma center in full cardiac arrest and has no organized cardiac activity. There is a large pericardial effusion, and I'm assuming that this patient had tamponade physiology that led to his arrest. But the fact that this patient had asystole, no further resuscitative efforts were performed, and the patient was pronounced. Concludes the lecture on the use of focused echo in the crashing patient. Hopefully these cases have given you some insight in how to use focused echo in the evaluation of the crashing or the cardiac arrest patient. Remember, you can also extend this, in a sense, do a medical fast exam, looking then if the cardiac findings are suspicious for the presence of intra-abdominal hemorrhage, a ruptured AAA, a ruptured ectopic. So there's a lot that ultrasound can be used for to rapidly diagnose these critically ill patients. Just remember, in the patients in cardiac arrest, it's all now about performance of uninterrupted, high-quality CPR. So only do these echo exams during the breaks, and do them only for a brief duration of time.